Will you start?
So good evening and welcome to one and all. I would like to request the attention of all the faculties and delegates. I will take few minutes of yours. I'm Ankita from Clarnet, the science session assistant for a seamless experience. And Clarnet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. Clarnet is very proud to be digital partner for this event organized by Society of Onco Anesthesia and Perioperative Care. And topic of today's session is anticipatory prescriptions in the end of life care. Now let's begin today's session, for which I would like to invite Dr. Meenakshi ma'am to take over. Over to you, ma'am. Kindly proceed with your talk.
Ankita, can
Thank
you
you.
display Dr. Meenakshi's slide so that I can introduce him? Thank you. Dr. Meenakshi is a chairperson today. She is associate professor in anesthesia and palliative care at Cancer Institute, Adyar. And she's devoted herself to palliative care exclusively for the past 2 years. So we've got an excellent store of knowledge there. And I would like to invite Dr. Meenakshi to introduce Dr. Praneeth. And welcome to you all. And if you would like to put in any questions during the session, please use the chat box. Over to you, Dr. Meenakshi.
Thank you. Thank you, Dr. Anjali, for that kind introduction, and welcome all the participants and our faculty for today, Dr. Praneeth, who's a good friend. So Dr. Praneeth is a consultant in the onco-anesthesia, pain and palliative medicine department at Basavatarakam Indo-American Cancer Hospital and Research Institute at Hyderabad. He established the Department of Pain and Palliative Medicine at the aforementioned institute, and he has also he's the faculty and is facilitating the DNB Palliative Medicine program at Indo-American Basavatarakam Hospital. And currently, I think it's the third batch of DNB residents are in training. His interests are end-of-life care management, management of difficult cancer pain. He's also doing research in symptomatology, identification and management of futility of treatment in ICU is also a pet topic. And I can understand why he was the faculty for this, this particular session. I can't wait to hear more about this topic. And as onco-anesthesia residents, this is an area where we'll all encounter this. So I hope your ears are glued to the presentation. Over to you, Dr. Praneeth.
Thank you, madam, and thank you, Anjali, madam, Dr. Meenakshi, madam. Thank you for the kind introduction. So, shall I share the screen now?
Absolutely.
Yeah. Okay, moving. Are the slides moving? Yeah. Right.
Yes, moving.
Yeah. Okay, so I will start with the case scenario. This is a case scenario of a 36-year-old female who is a resident of Karimnagar, interior Tier 2 city in Telangana. She's a mother of 2 children, and she approached a local clinic with complaints of dull aching pain in the upper back since past 1 month, weakness in the lower limbs for 10 days. And on further evaluation, she was advised various scans and biopsies, as in most of the cases. And unfortunately, it turned out to be stage 4 lung cancer with liver and skeletal mets. She presented very late. She was referred to a tertiary cancer hospital, which is our center. And over this period, she became progressively breathless, developed sensory loss in her lower limbs. And after coming to our hospital, she was evaluated by a neurosurgeon because of the progressive lower limb weakness in the emergency room. Case was discussed with the medical oncologist, and because of the poor performance status, consensus was made about best supportive care. The neurosurgeon explained that any intervention may not be able to help her regain power in the lower limbs, and he advised against the surgery. But in her case, the husband was guilt-driven. Because he could not approach for earlier medical attention despite the wife's suffering, he kept on delaying medical attention. And at this point of time, he wanted to do everything which is possible. And against repeated counseling, he requested an emergency laminectomy surgery. So we had to post this patient for surgery. This is a real case which happened in our setup. So the course in ICU, intraoperatively uneventful apart from the slightly higher requirement of the fraction of inspired oxygen. On first post-operative day, as usually our protocol is we extubate the patient immediately after surgery in the operation theater, but this patient had to be extubated on the POD1. So on POD1, we extubated the patient and immediately put the patient on high flow nasal oxygen. On POD2, patient had increasing respiratory distress on high flow nasal oxygen, but was able to maintain. On POD3, she became progressively worsening clinical condition and ABG parameters kept on deteriorating as well as her sensorium. So in the middle of the night, a decision was made to intubate and the attender wanted to do everything possible. This was what he was saying. So POD4, persisting high FiO2 support, hemodynamically stable, mentation improved. The patient and the family started having hopes again that the patient is recovering. But on the POD5, the patient developed worsening clinical condition. In view of the sepsis, in view of the continued high ventilatory supports, palliative care consultation was made at this point on the 5th post-operative day. Course after palliative care consultation, husband was counseled about ongoing events and the futility of the ICU treatments. This was done by the palliative physician. He did not agree to be shifted to the ward, but he believed in magical realism. He was waiting that he made a special prayer to the Jesus Christ, and Jesus Christ will always do something good for them, and he wanted to wait for a particular date that will be coming 3 days after the day of consultation. He said that after that 3 days, if there is no clinical improvement, my prayers will be, I feel that my prayers are unanswered and I want the patient to be shifted to your ward. You can do as you wish, but for these 3 days, continue treating in ICU. So we waited for another 2 days and then requested for a transfer to home. And then after 2 days or 3 days, he only requested for a transfer to home to facilitate dying at home. So this is the clinical scenario. And all of you residents and onco anesthesia fellows, please ask yourself, if you are in this, you might have experienced such a similar situation in your setup also, because many times we do operate patients and the patients sometimes they do not do well in the post-operative period. So as an onco anesthetist and a critical care physician, what do you think is your role in this particular situation when the patient attendant is asking that please facilitate a transfer to home? How do you facilitate transfer? How do you facilitate the transfer of this patient? What are the anticipatory symptoms and prescription in this particular case? Because after passing with your fellowship, all of you may not be having a good palliative care backup. So sometimes it is required for you to take up the role of a palliative care physician as well and need to facilitate these things. So my intent of this lecture is to stimulate you in that particular direction and help you facilitate taking decisions which are in the best interest of the patient and your institution. So coming to the theoretical aspects, what is end of life care? End of life care is a time frame to the estimated length of life, which is the most commonly cited time frame as a period of fewer than 6 months of estimated life. An approach to a terminally ill patient that shifts the focus of care to symptom control, comfort, dignity, quality of life, and quality of dying rather than the treatments aimed at cure or prolongation of life. End of life care pathway is a document that guides the care plan for the final weeks of someone's life. It is recommended to be used wherever the person wishes to die, whether it is the hospital, care home, or in their own home. So this end of life care pathway document can be handed over to them, and it guides the patients and their caregivers the care plan of their final weeks. And what is terminal phase? What is the difference between terminal phase and end of life care? The end of life care, as I mentioned, in the final 6 months before dying, and terminal phase is identified as a period of irreversible decline in the functional status. That is, we know that the death is imminent and which is nearby. Terminal phase can last from a few hours to days and occasionally to weeks. So it also can be mentioned in palliative care textbooks as actively dying phase. So principles of the end of life care symptom management are: symptoms should be assessed at least once a day. Anticipatory prescription can be considered. Availability of essential medications has to be kept near the patient and attendant. Medications and doses must be prescribed for symptom control based on careful evaluation of the patient's symptoms, and frequent reassessment is required. So many people, they express a preference to be cared for and die in their own home. This is what many Indian people want to be, like that, to be that I should be dying comfortably when I'm sleeping in my home. But what is reality? What is happening outside? Respecting a patient's wishes for about a preferred place of care is a contributory factor to achieving a good death. Although the place of death is a key indicator of the quality of end-of-life care, it is recognized that dying at home is not appropriate for everyone. A good death is dependent on good symptom management, compassionate individualized care, and comprehension of what is important to the dying patient. Improving access to the community palliative care services is a key to supporting a patient's wish to die at home. So, an important consideration which has to be made is the need to anticipate what symptoms the patient is likely to experience as they approach the end of life. What are the kind of symptoms that can be projected? And we need to ensure that there is immediate access to the necessary medications where, in this particular stage when the patient is progressing towards the end of life. Prescribing medications in anticipation of need can avoid lapses in the symptom control and the associated distress. So we need to think that these are the symptoms that the patient can be having in the future coming days, and these are the medications you prescribe. The patient may have breathlessness, you can prescribe lorazepam, SOS, etc. So anticipated prescribing can be defined as a proactive prescribing of the medicines that are commonly required to control symptoms in the last days of life. There are 4 distinct phases of anticipatory prescribing. First is initiating the conversation with the patient and their family, writing the prescription, dispensing the medicines, administering the medicines to the patient. So anticipatory prescribing is a widespread clinical intervention and helps controlling distressing symptoms for people dying of expected causes at home or in care homes, not in a patient who is not in a patient who is having sudden deaths. It is written for the patients who are expected to die of expected causes. So the intent here is to optimize the timely symptom control in the community and prevent crisis hospital admissions. In all care settings, however, it is important to prepare and anticipate symptoms that may arise to ensure that the dying person and those important to them do not experience undue distress. It relieves the caregiver distress as well. So anticipatory prescription is a complex intervention. There are multiple steps which are involved, including several layers of teamwork, nuanced skill judgments about both when to prescribe and how to prescribe medications. The standardized medications and doses that are prescribed are not always clinically appropriate, but the practice is prone to miscommunication and adverse side effects also, especially when several healthcare professionals and services involved, like the famous saying, too many cooks spoil the broth. Anticipatory medications carries great symbolic and emotional impact for the patients, families, and signifying the imminence of death. So the practice places a heavy burden of responsibility in the family carers. They are expected to manage supplies, request use of medicines, and securely dispose those medications. So the symptoms that are commonly expected in symptoms that commonly occur in the last few hours to days of life are delirium, anxiety, agitation, nausea, vomiting, respiratory secretions, respiratory distress, etc. It is the practice of some of the clinicians to prescribe 4 or 5 medications, and these frequently will be in the injectable form, or as the oral route may not be possible or effective as a person approaches death. They can be used as required or may be prescribed as a 24 hours continuous subcutaneous infusion via syringe pump. So the anticipatory drugs usually contains these classes of drugs, including analgesics like morphine or diamorphine, antiemetic like ondansetron, levomiprazole, antipsychotics, for example, haloperidol, anxiolytic like midazolam, and anti-secretory agents, for example, hyoscine butylbromide, glycopyridine. So this is an example of an anticipatory prescription. So when we give the patient, it should be usually on a pre-printed sheet, not a handwritten prescription, because there is a chance that the patient attender or caregiver may misunderstand the information which is there. So we need to write them why this prescription is given also. Sometimes they may misunderstand midazolam to a painkiller, and they may give midazolam to a patient who is complaining of pain. So to avoid this miscommunication, we need to write the class of drug, we need to write the medication name, we need to write the action which is intended, and mention that it is the subcutaneous dose or route of administration has to be mentioned, and the indication why we are giving. Analgesic indication is pain or breathlessness, etc. And how many ampules you are prescribing also should be written on a pre-printed sheet. So this is an example of an anticipated prescription where morphine sulfate given 2 mg subcutaneously as needed in an opioid naive patient. Midazolam, which is given for anxiety or anxiety distress myoclonus, and 2 mg subcutaneously hourly or as needed. Excuse me. Hyoscyabutyl bromide 20 mg subcutaneous hourly or as needed, and given to manage respiratory secretions. And the number of ampules that are dispensed: levomepromazine 2.5 mg to 5 mg subcutaneous 8 to 12 hourly as needed, and given for nausea, vomiting, and how many ampules that we have dispensed. Again, this is recommended medications which are needed in a anticipatory prescription. So the principles of anticipatory prescription are: reversible causes and symptoms should be treated where appropriate. Non-pharmacological methods should also be considered. Example, repositioning to manage the respiratory secretions. This is very important. Involve the dying person and those important to them in making the decisions about symptom control in the last days of life where possible. We have to have an individualized approach. Even though it is a blanket kind of prescription, you need to assess your patient individually and manage the symptoms accordingly. Assess what medicines the patient might need to manage the symptoms which are likely to occur in their last days of life. So when deciding which anticipatory medicines to take to offer when taking into account, we need to see the likelihood of specific symptoms occurring, the likely cause of the symptoms, benefits and harms of prescribing that or administering the medications, benefits and harms of not prescribing or administering the medications, possible risk of the person suddenly deteriorating, for example, catastrophic hemorrhage, seizures, etc., for which urgent symptom control may be needed, the place of care and the time it would take to obtain medications. So all these things have to be considered, discussed with the patients and the caregivers, and explain to them, and then the medications are prescribed. So we need to specify the indications for usage as I've already shown in the previous prescription, and the dosage of medications that are prescribed, and start with the lowest effective dose. Specify an appropriate route for administration. That is, the patient, if the patient is unable to tolerate oral route, we need to go for subcutaneous route. And if the patient is requiring more than 2 or 3 SOS doses or PRN doses, we can consider for a syringe pump, and a syringe pump related syringe pump and a subcutaneous infusion pump can be considered. Review symptoms before and after anticipatory medications are administered. Monitor for benefits versus side effects at least daily, and adjust the individualized care plan and prescription as necessary. So this is a slide which shows the healthcare professionals' reflections on the decision-making process for anticipated prescribing. So there can be concerns about the medication, there can be concerns about the patient-professional relationship, patient factors which include inability to take oral medication, reflections and expertise and experience, knowing what to prescribe, difficulty in recognizing dying. Sometimes the nurse may think that the patient is dying, but actually it is a breathlessness which can be managed by medications. Non-cancer conditions, it presents a dilemma for us. Concerns about accountability, that how accountable the patient attender is, that they will bring out, they will deposit the rest of the remaining drugs. Importance of the professional relationship, that out of hours and usual care, out of the working hours, who will be able to cover the patient, community and hospital professionals, specialist and generalist palliative care teams, and the resourcing problems like concerns about medication waste, limited availability of drugs, lack of available equipment, etc., have to be considered. So this is a guideline, nice guideline, which is published on 16th December 2015, approximately 8 years before. And the guidelines talk about recognizing when people are entering in the last few days of life, that is recognizing the people who are actively dying, communicating and shared decision making, clinically assisted hydration, medications for managing pain, breathlessness, nausea, vomiting, anxiety, delirium, agitation, and noisy respiratory secretions, anticipatory prescribing. So if anticipatory medicines are administered, monitor for benefits versus side effects at least daily, and give feedback to the lead healthcare professional. Adjust to the individualized care plan and prescription as necessary. So this is a just in case box. So just in case when the patient is having these symptoms, these medications have to be used as early as possible for the symptom control in the last days of life. So this is a just in case box which has midazolam, morphine, buscopan, and levomepromazine for managing the psychosis. Presence of just-in-case box provides reassurance to the patient that we can manage the symptoms with minimal delay in the home and avoiding unnecessary distress. The contents of a typical just-in-case box usually contains anticipatory medicines, which I have already discussed, needles and syringes, prescribing guidance. This is also very important. Authorization to administer medication document, which is not usually followed in India, but there it is followed in the Western countries where they authorize a particular person to administer medications after they feel that the person has a reasonable understanding of the route of administration and the indication for which the drug has to be given. Patient and caregiver information leaflet, contact details for advice. So, new evidence is coming up on anticipatory prescribing, which says that anticipatory prescribing is widespread, but we do not know what extent it helps in controlling the symptoms. The widespread practice of anticipatory prescribing and its underpinning policy is based on the clinician's perceptions that the intervention offers reassurance to all involved and provides effective, timely symptom relief. These medications are prescribed between 38 to 51% of the patients who are dying in the people who are dying in the community. But there is inadequate evidence to draw conclusions about their clinical and cost effectiveness and safety. So in the UK, they are prescribing anticipatory medications for the people who are dying in the community, and the prevalence of prescription is 38 to 51%. In Indian setup, it is not even 5% is what I assume. Standardized medications and doses prescribed ahead of need are not always clinically appropriate. The timing of such prescriptions is challenging given the prognostic uncertainty for patients, especially those with non-cancer conditions such as dementia, multimorbidity, frailty in old age, where illness trajectory may be unpredictable and dying is protracted. That is, a long period of dying happens. So here the prescription, giving prescription is challenging. Not all dying patients need these drugs. Sometimes we prescribe so many medications, but the patient may pass off comfortably. So between 40 to 54% of the patients prescribing anticipatory prescriptions do not go on to receive any of these medications. The presence of medications may be interpreted by visiting clinicians who are unfamiliar with the patient, and they do not know that care should focus on the last days of life, even when this may not be the case. Delays in differing views can affect the administration or use even when the anticipatory medications are in place. Once anticipatory medications have been prescribed, it is often the family members who initiate their use through request for a professional help to control distressing symptoms, particularly pain. The time for the professional help to be coming can vary, and the time from nurses receiving a family request to administer medications to giving the dose can vary greatly, with one UK multi-site study reporting a median time of 105 minutes. Less experienced nurses considerable unease, and some nurses report that they lack the confidence to initiate injections or adjust doses. Family carers reported that it is easier to persuade nurses to administer further doses once anticipatory medications had been started. Families and carers are often uninformed about anticipated medication. So anticipatory medication. The presence of anticipatory medications in the home can be simultaneously reassuring and unsettling, reminding patients and their families of the impending death. So sometimes they feel that these medications being present in their home can itself be a sign of death, and they may get apprehensive. So consequently, patients and the families can worry that the injectable medications, especially opioids, could cause oversedation and can even hasten the death. So these misconceptions can be cleared by a proper goals of care discussion and explaining the medications in a proper way. For some families, keeping anticipatory medications in their home may be unacceptable or inappropriate. They may feel it is culturally inappropriate. There can be small children at the home and they may be fiddling with the drugs. So it is unacceptable for them. So we need to consider these issues as well. Families carry heavy responsibilities for anticipatory medications. Families carry out considerable work in managing medicines for the dying patients, which is largely unseen by the health professionals. They assume responsibility for accessing medication supplies and resupplies from the community pharmacies, and ensure professionals visit to give anticipatory medications when needed. And professionals, for them to come and give anticipatory medications when needed is not always possible. Finally, bereaved families are expected to return unused drugs to a pharmacy for secure disposal after a particularly difficult time. It is not known what happens to much of the leftover medications, because not all families come over and return those medications. So this body of research clearly tells that prescribing of anticipatory medications is not simply the fix in controlling distressing symptoms that we as health professionals often hope it to be. Like we think that prescribing these medications, our job is done, but this is not the simple solution. Anticipatory prescribing is a complex and sensitive intervention requiring careful thought, person-centered discussion, and regular reviews, often across multiple community providers of care. So this was given by Dr. Ben Bowers, primary care unit, University of Cambridge. So there are 4 aspects to improving symptom control at the end of life. There are 4 areas of action: responsive communication between families and healthcare professionals, responding to changing clinical needs, which can be achieved by regular assessment, providing support 24/7 by having a very good robust system, and listening the insights of families and their carers. Excuse me. The subject of anticipatory prescription should be used as an opportunity to hold open, tailored, and honest conversations about patients and families' concerns about the realities of dying. And if they indicate that this is their preference, rather than being used as a clinical strategy to keep the discussions vague. Maybe that the patient may experience these things, and certain words which we use, they may be creating more confusion in the patient family. So when we have got an opportunity to do an anticipated prescription, we need to establish rapport with the patient and the families, explain their queries and their concerns, and address them in a better manner. Community nurses and general practitioners require the skills and training to explore sensitively and confidently patient and family preferences for information and their concerns about the dying process. So responding to changing clinical needs, that I have already said that we need to review the patient regularly, and we need to check the prescribed anticipatory medications and the doses ranges are reviewed regularly, and these drugs are administered when they're clinically appropriate. Also, we need to check when yesterday the patient had breathlessness, but you have prescribed morphine, but I had a fear that this morphine might further aggravate the breathlessness, so I haven't given, is what the patients sometimes say. So need to check that these anticipatory medications are given to you. Your job is to deliver to the patient, administer to the patient whenever he's having this particular symptom, is what we need to reinforce to them. This involves sharing the records across the services, regular interdisciplinary meetings between general practitioners, community nurses, and specialist palliative care team members to discuss and respond to patients' changing end-of-life care needs. Providing 24/7 support, I have said that there is need to be a robust system for this. These services need to have the resources to be able to provide responsive care and visit to assess and address symptom control needs in a timely manner. This would improve the patient and family confidence in systems and reduce the necessity to prescribe anticipatory medications too far in advance for the potential need. And lastly, listening to the insights of families and carers. Community nurses and paramedics require consistent, comprehensive training in the recognition of and appropriate responses to end-of-life symptoms and the appropriate administration of anticipatory medications. This is what we train our social workers, nurses in palliative care, that we need to identify. We tell them how to identify that the patient is dying. So, and what are the symptoms that the patient will be having in the end of life and how to manage them. So this includes training in working partnership with the family carers and recognizing how to draw upon their insights when patients are no longer able to communicate their levels of comfort. So the system level changes that are required are responsive communication, 24/7 support, responsive to changing clinical needs, listening to the families and carers. The British Medical Association gave guidelines of a best practice, and they said that the prescriber must accept responsibility for prescribing in anticipation of need and be mindful that the availability of medication does not replace the need for clinical assessment when the patient clinical condition changes. So, excuse me. So, the availability of medication does not replace the need for clinical assessment when the patient's clinical condition changes. So, here we need to be careful that when we write the prescription, our job is not done. We need to confirm and we need to do regular reassessment to change to assess the dynamic clinical condition. And we need to agree the list of anticipatory medications locally with the stakeholders, reduce the risk of prescription errors by agreeing on the recommended pre-printed charts. Balance the quantity supplied between adequate supply and potential wastage. We need to include equipment and documentation to facilitate administration of medications in the just-in-case box. Be self-assured that the patient and carers understand the rationale for placing medications at the home. Ensure that all the healthcare professionals involved in the care of the patient are aware of the clinical situation and the availability of anticipatory medications, including those providing the out-of-hours services. So this is an article which is published in the BMC Supportive Palliative Care Journal, 2023 October, very recent. So they talked about anticipatory prescribing in community end-of-life care. And this was a retrospective audit of community palliative care patients at the end-of-life care prescribed anticipatory medications. The choices were analgesic, antiemetic, antisecretory, and anxiolytic medications. Haloperidol was the most favored antiemetic here. Antiemetics may not be universally required, and individualized prescribing was cost-effective and safe at a local level. This is the conclusion. General practitioners' decisions about prescribing end-of-life care anticipatory medications. This was a qualitative study. So the study found that general practitioners prefer to prescribe anticipatory medications weeks ahead of their likely need whenever possible. They recall framing information about the drugs in their uses in ways that ensure that patients and families are willing to have them in the home. After prescribing anticipatory medications, GPs rely on nurses to judge when to administer drugs and to keep them updated on patients' end of care. So there is risk involved, and we need to balance the risk of storage of controlled drugs versus possibility of diversions and drug abuse. So this is an infographic which is given to the patients and caregivers. So there is an infographic. When it is given, it actually helps the illiterates also have a better understanding. So here, this is an infographic about managing patients' breathlessness action plan. And they say everyday management, syringe driver with morphine and midazolam has to be changed daily by the nursing staff. Handheld fan, ceiling fan, or desk fan circulating to give the sensation of increased airflow. So these are the these are the pictures which are given here. When increased work of breathing or shortness of breath occurring, non-pharmacological measures like wherever possible, sit up straight, remain calm. Family, please speak in a soft voice when giving instructions. So this will help us opening the airway. Make sure that you have your fan and let it blow on your face like the one which is provided in the hospital. And take slow, deep breaths in through your nose and out through your mouth. So this is called diaphragmatic breathing, and this can help relieve breathlessness. Give Ordain. This was a guidelines which is taken from the Australia. Ordain is a oral morphine liquid, and it is available in 2 mg per ml. 1 to 2 ml oral syrup when feeling shortness of breath can help reduce breathlessness. So if the patient is able to swallow, lorazepam 0.5 mg can be given. But if he is not able to swallow, it can be placed under the tongue to let it dissolve. So lorazepam can reduce anxiety associated with the breathlessness. So there can be other instructions about the healthcare numbers. If the patient is still not feeling better, how can you call your palliative care nurse? And prior to bathing and toileting, what are the steps that the patient has to follow, etc. Anticipated medications also need to be modified for people dying from non-malignant disease, such as a frail older patient with multiple morbidities. You cannot assume that these are the 4 classes of medications which are given in the patients who are dying with cancer. The same medications, same 4 classes of drugs, which can be applicable. You don't think that these can be also be applicable for the patients who are dying from non-cancer conditions with multiple comorbidities. GPs may be reluctant to prescribe medicines when they have diminished control over administration. So prescriptions that are incorrectly written can result in significant delays in supply, particularly during the out-of-hours period and when controlled drugs are prescribed. So this is a ESMO clinical practice guidelines about the care of adult cancer patients at the end of life. They speak that that patients in the last weeks of life, nutritional interventions. So we have prescribed about the drug classes like anxiolytics, drugs to relieve breathlessness, and drugs for relieving pain. But many common requests that we find in a palliative care practices, patient is not eating in their last stages. Can you write some IV fluid so that we can give the patient at home? But what is the evidence for prescribing IV fluids at home? So they say that for patients in the last week of life, nutrition interventions are rarely indicated, and care needs to be primarily targeting alleviation of hunger if present. Only if the patient complains of hunger, then only try and relieve that hunger, thirst, and other distressing symptoms. Nutrition, however, may be less important when approaching last weeks and days of life, as there is reduced intake of food and liquids caused by anorexia, cachexia, dysphagia, delirium, and reduced desire for food. It's a part of natural process of dying. family members and carers often experience a high level of distress. The decision to hydrate patients by IV or subcutaneous route at end-of-life care remains controversial, and artificial hydration, which is given through IV or subcutaneous routes in the last days of life, has not been demonstrated to prevent or relieve symptoms of thirst, dehydration, or delirium in a randomized trial. See, this is an anticipatory prescription and advanced care planning in palliative care for children and young people. So, for people who are being cared closer to home, there continues to be an increasing demand for children and their families to be cared at home. Thus, there needs to be significant push for services to develop models of care that allows patient to be looked after out of acute hospitals and closer to home, with the aim of providing choice in place of care. So, the NICE guidelines have focused numerous areas where the sources of pain can be overlooked, like neuropathic pain, gastrointestinal pain, bone pain, bladder pain, pressure ulcers, headache, musculoskeletal pain, dental pain, etc. So, in practice, fears around the opioid use can be seen frequently and can result in non-compliance and therefore unnecessary suffering by the child. Open discussions establish therapeutic relationship with the family to prevent this particular fear. So, for managing agitation when the patient has neuro disability, signs of agitation or delirium can be mistaken as seizures or dystonia. So, this highlights importance of multidisciplinary approach and key attention. Managing seizures and dystonia, symptoms related to respiratory distress cause the most fear and anxiety in children, and so it is important to consider the use of supplemental oxygen, bronchodilators, and opioids. The accumulation of airway secretions are seen commonly, managed by repositioning, suction, drugs to reduce secretions such as hyoscine hydrobromide or glycopyridine. So this is a study which focused on management of terminal bleeding in patients with advanced cancer. And they said that sedation can be given in these patients to relieve the alleviating distress and providing comfort to the patient. And the other non-pharmacological measures like use of dark towels, use of suction, use of sedative crisis medications pharmacologically, and like midazolam, diamorphine, or ketamine by subcutaneous intramuscular or IV administration has good evidence. So this is a study about the use of crisis medications in the management of terminal hemorrhage due to incurable cancer, a qualitative study. And they said that the participants who are included here are the palliative care and head and neck oncology nurses. So the interview was taken from the nurses, and they have reported crisis medication to have little or if any role in the management of terminal hemorrhage. During the time of terminal hemorrhage, don't think to use Tranexa or FFPs or any other medications which probably do not have any role. And because terminal hemorrhage is a rapid event, that patients died even before it could be, these essential drugs can be administered. As many events have not been predicted, anticipatory prescribing of crisis medication did not always occur. Staying with the patient and supporting the patient using dark colored towels to camouflage blood are reported to be of more practical use. Thus, anticipatory prescribing of crisis medication rarely benefits the patient and may unintentionally distract the patient, distract from the nursing care. So, we have talked about anticipatory prescription in a home care setting or in a community setting or a hospital setting. But is there a role of anticipatory prescription in the hospital setting? It can be given when when the outcome is expected, the reversible conditions have been addressed, futility of the further interventions has been documented, and it can be helpful for the nurses, duty doctors to focus on other important issues once anticipatory orders in terms of SOS medications are charted. So the future areas for research are investigate the last days of life symptom profiles of the patients dying from a range of conditions in the community. We do not know what are the kind of symptom burden that the patient has for the patients who are dying in the community. This would help to inform anticipatory prescribing guidance and decisions. Well-designed observation studies are needed. Investigate the impact of anticipatory prescribing on the patient symptom control and rates of crisis and end-of-life hospital admissions. Identify and put in place optimal system-wide approaches so that the anticipated medicines can be prescribed and used safely, effectively, and at the right time. So, necessary to say that governmental support is very much needed here. And develop an Indian guidelines for anticipated prescription of essential drugs and narcotics. How many drugs that can be prescribed safely in an Indian setup? How many ampules of morphine can be given to the patient? How many ampules of haloperidol can be given to the patient? We need Indian guidelines for this. We are lacking in this area. So, to conclude, recommendations and link to evidence has to be done, and anticipatory prescription has to be individualized towards the patient, and a blanket prescription cannot be written. Prescribe as early as possible. Review regularly and adjust the individualized care plan and prescriptions as necessary. Anticipatory prescribing is a process rather than a one-off episode. Uncertainty remains as the impact of anticipatory prescribing on outcomes such as preferable place of death and symptom control, and also uncertainty as to what should be prescribed often exists. So the future scope is no study till date has investigated the patient's views and the experiences of anticipatory medications and their preference for involvement in decision making. We can plan good studies in this area. So coming back to our case, as an onco-anesthetist and critical care physician, what is your role? So our role here is coordinating with the primary physician, palliative care department, and the family, help them facilitate family meeting, and help them understand by honest discussion of the goals of care, describe the anticipatory symptoms and events, and anticipatory prescription can be provided. So how do you facilitate the transfer? We can consider compassionate extubation in the ICU, or versus shifting the patient to the ambulance and extubating the patient in the ambulance can be considered. Transfer the patient till home on endotracheal tube only. Yeah, sometimes when the patient feels that no, I don't want this tube to be removed till the patient goes home, then you can transfer the patient till home on the endotracheal tube. Training the caregiver how to handle the Bale circuit, ambo bag, etc. Monitoring for signs of respiratory distress and correctable reversible issues like tube block, etc. And what are the anticipatory symptoms and prescription? This patient who was operated for laminectomy may have pain. Opioids can be prescribed. She may experience difficulty in breathing. Benzodiazepines and non-pharmacological measures can be explained. Respiratory secretions can be experienced that the patient is already intubated. Glycopyrrolate, hyoscine bromide can be given. Anxiety, delirium, etc. can be there, and haloperidol, benzodiazepines can be prescribed. So these are the references that I have used. And in anticipation, I'm saying thank you.
Thank you, Dr. Praneeth, for that crystal clear and very practical approach to managing end-of-life situations with anticipatory medications, and taking us through that case scenario, putting everything into perspective. So there were two questions in the chat box. So which I had answered, but I'm curious to know what your answer would be. So shall I read it out, or you have access to this?
What could you please recommend institutes where palliative care fellowships are available? This one.
No. There is the first question was by Dr. Anjali Gera, and she wanted to know why this patient in your case scenario was taken up for surgery. What was the post-operative course anticipated, and why is it that palliative care was advised on the 5th?
Okay, great.
Okay,
so
it's in the Q&A.
Okay.
And why was the palliative care asked for on the 5th post-op day?
All right. So many a times, even after repeated counseling, the patient not to go for surgery, it is sometimes because of the pressure of the patient family, and they say that we are open to everything, and they convince us that they had to be taken for surgery. And this can be experienced by almost all of the physicians, that sometimes we need to give up to the patient's wishes, and we cannot just say, because in this case, the patient is a young patient. She is a mother of 2 children. So even though the indication was not there to perform surgery, the husband was convincing us to go for surgery. And palliative care consultation was given on day 5. It's because the patient was being planned for surgery, worked up, and at that particular stage, the symptom management is being done by the anesthetist, but they are also facilitating goals of care discussion. But the palliative care physician has been called on POD 5 when the clinical situation doesn't seem to be improving, and they wanted the patient to be shifted out of the ICU in view of the ongoing financial distress and other conditions. So this is my answer. at the insistence of the family, as you rightly mentioned, madam, she had widespread medicine may have contributed to deterioration. Palliative care definitely could have been initiated earlier, but in our institute, we do initiate palliative care earlier, but the patient was being considered for surgery and being worked up for surgery, and amidst of all this, palliative care consultation was not was done on day 5. How do you ensure that opioid advice for patient who is on end-of-life care at home is used by the patient only and not by patient's attenders?
Can I interrupt for a minute?
Yeah, madam. Yeah.
Stop sharing. We can see the video.
Achha. Oh, okay. Yeah, stop sharing. Yes. So, how do you ensure that opioid advised for the patient who is on end of life care at home is used by the patient only and not by the patient attenders? So, for this, we need to identify a responsible caregiver. We need to have a detailed discussion and tell them that this should not be used by any other people apart from the patient. And we can ask the patient to bring the empty strips or empty ampules when they're when they're coming for a refill of narcotics. So there are several ways where we can ensure, and we also can see the adequacy of symptom control with the drugs. And if there is any suspicious behavior, then we need to investigate in that direction. But yeah, apart from also after taking all these precautions, we sometimes may have lapses, but impeccable assessment has to be done regarding these things.
So there's one more question by Dr. Teja, who's asking, since the most common route of administration is the subcutaneous route, what happens if the patient has Anasaka and the subcutaneous route is contraindicated?
What do you do in your situation? In your setup, madam? Yeah, this is a quite challenging situation for us. Sometimes we can go for intraosseous administration.
But honestly, we have had few patients with Anasaka. But luckily for us, patient did not lose consciousness, and I think crushed morphine or glycopyrrolate or lorazepam tablets, mix them with honey so that the volume isn't much and easy to administer. So that's what we had prescribed. And at this point,
consider an oral route in this case by putting a Ryan's tube or something.
Even just the regular route, it works. And sometimes, in our situation, sometimes 24/7 coverage, or, to be able to visit every patient who is facing end of life may not be possible. So, keeping all that in the picture, we could, just give tablets and tell them that if push comes to shove and you don't have anything else that you can help with, this is something you can do. So,
Dr. Anjali Gera is lifting hand. Is there? Can we unmute her if she wants to speak? Dr. Anjali Gera has lifted the hand.
Yes. Do you use methadone for managing cancer pain in palliative care?
Definitely. We are using methadone. So methadone is considered for those patients in whom increasing morphine requirements are happening, or in the patients who are unaffordable and having renal failure and probably having very deranged parameters. And those who are not on multiple medications, we consider methadone in them after identifying that the caregiver is appropriately trained and that this medication has to be given 3 times in a day. We are using methadone syrup, which is currently available in our Hyderabad. Methadone tablets are not available with the pharmacy people. So, methadone is a good drug and it has helped a lot in patients having neuropathic pain, CS cervix, who are usually prone to go for this obstructed pelvic calcium system and developing renal failure later. We are going for methadone in them, giving us quite a good amount of results. Almost 700 patients till now we have used methadone.
just wanted to add that methadone would not be the ideal choice in the end of life situation.
Yeah,
So
not in
just
the end of
for
life
the
situation.
listeners, just for the listeners, in the context of this context of the session, methadone or transdermal fentanyl is not something which you would use in this situation. So are there any other questions? I think there's something else popping up. Yeah. No, nothing else.
Could I ask a question?
Yes,
madam.
definitely.
How often is it that the oral route is actually unavailable? Would that not be the preferred route of administration?
Yeah, madam. So in the last few days of life, last few hours of life, sometimes the common symptoms that the patient might experience is shortness of breath, delirium, are the one of the two common symptoms. The patient is delirium. They may not be compliant to take the medications.
Yeah.
Shortness of breath, probably there is risk of aspiration. We are not comfortable using. And apart from these conditions, there are patients who are having CA, esophagus, head and neck cancers, etc., etc. From them, the oral route is stopped even way before. So there are use of alternative routes like subcutaneous routes or IV intravenous medication, intravenous route has to be considered on case-to-case basis, and it is often that we need to depend on the alternative routes other than the oral routes in the dying patients.
So these would require trained personnel to administer.
Subcutaneous medication, probably once we train the caregiver, not much of training is required. Yeah, but if the patient has to be repeatedly placed on repeated IV injections, definitely a trained nurse or someone who is better able to manage these things is required.
Just for the audience, I wanted to mention that Dr. Anjum Khan Jod was to chair this session, but Dr. Meenakshi has stepped in at short notice, for which I thank her, because there was an emergency situation and Dr. Anjum could not make it. I think Dr. Praneeth has URTI as well, but he's managed to get through the lecture.
Yes.
Thank you, Praneeth. I also wanted to ask the panel, there are a lot of anesthesia residents or fellows who are currently interested in taking up palliative care. So are there any palliative care fellowships that you could, which institutes
So
are holding, what sort of, how would they apply for it?
So there is one PDCC course which has opened recently in the Indore. Dr. Pankaj Singh, who is a pass out of TMH Mumbai, and later he did he worked under Dr. Naveen Salins as a consultant in Manipal Hospital. So he started a PDCC course, one and a half year course, and there are CCEPC courses, which consists of Part A and Part B, which are held online.
EPC?
Certificate course in essentials of palliative care.
Yeah. So this is this doesn't require that much time, madam. 5 days of lectures and 10 days of observership. You will be able to get a CCEPC certificate, and after this, you are able to prescribe oral morphine as well. So this can be a good beginning step for the people who are pursuing fellowship in onco-anesthesia to understand and improve their palliative skill expertise as well.
There's also 2 distance fellowships, which are 1-year fellowships, which involve 10 days of didactics and 20 days of clinical observation at 2 different centers of your choice. And one is at Pallium, India in Trivandrum, and the other is at Institute of Palliative Medicine at Kozhikode in Kerala. Both are in Kerala. So those are also fellowships available, but require a little more time investment, and there are the curriculum is very much structured, and you have online assignments and a practical exam, OSCEs. You have some research work. So those require a little more time investment, and
I did my NFPM last year.
I did too. Yeah. So
Okay.
so that those are the other avenues for training.
So Kerala is sort of the leader in all of this.
Yeah, they have a lot of community work going on.
Now
So,
we have
Online
now we
courses
have
are not-
3 years courses, madam. DNB, we have started DNB.
Yeah.
Dr. Meenakshi is also heading there, and I'm looking after in my institute. So
Qualification required would be MBBS, MD.
yeah, MBBS, madam.
Only
For
MBBS.
DNB program, only MBBS. Post MBBS, we are taking.
So would there also be a sort of a palliative care online course where people can judge whether they would like to take it up or not?
That is CCEPC course, madam. The part A and part B, which I was talking about.
That
I
will
mean-
give you a bird's eye view of the, structure of palliative medicine and, whether the candidate is wanting to take it forward in a
Right.
big way. Then they can go for a 1-year fellowship.
Okay. I believe there's a, I don't know whether this is right or not, but I think they have a weekend course in Tata. Somewhere on 2 consecutive weeks in August or something like that. Is
Okay.
something like that available?
Not
Elsewhere,
aware of
no.
it.
Yeah.
But there are enough options, depending on the time that you wish to spend.
Yes.
And would anesthetists, would you recommend anesthetists to take up palliative care? Are they well placed?
Definitely, madam. As I mentioned in the slide, see, sometimes not in every hospital that you find a good palliative care support, and sometimes you need to assume the role of multiple persons. So in this kind of situation, when you know that the patient is suffering and the treatment options are going futile, you need to have that intent of how to manage the patient outside the ICU and help them facilitate for a smoother journey and a better transition of care and better end of life care, which is a right for every person in the country. Why is it not happening? Because we are thinking that there can be legal implications of doing these things. We may think that we are already overburdened with our work. Why should we go and do some other thing? So ultimately, when it comes to your own family, you don't think in that manner. So, but it's a patient who is there. You'd think that you need not talk too much to the patient because you are a doctor and you need to show that kind of distance, maintain that kind of distance. But which I also used to think like in a similar manner. But after passing my MD, I kind of changed my approach towards this. There's nothing wrong thinking like that because we were not taught, but it is not all. It is never led to make a change in a better way.
I think this is a very important point that you brought up. I think all of us have been in this situation where we've had our relatives in the same situation and we do not know whom to turn to for help. So yeah, that is an important point. And the other thing was that you're right. There are sometimes we are called upon to provide opiate infusions to individuals who are about to die. So, and we are a little hesitant. How much should we give? What if the patient dies immediately after we start the infusion? What would your advice be?
Madam, first thing is we need to explain the patient and the caregiver the intent of starting the medication. What I would do is I would tell them, see, I'm not here to save your life. This medication, whether it is started or not started, your life has a very limited time. So by starting this medication, I'm going to make your journey a bit easier by relieving the pain. But after starting the medication, if something happens to you, don't think that this medication has done this. You're already in a process of dying. And this has been explained to you by the primary physician as well. I need to confirm with them also. And then we start this medication, telling them, explain the risks. And then I ask them a simple question: do you want the patient to be suffering in this manner? If you want your loved one to be in pain even when they are dying, I will not start. I will respect your decision and I'll move on. But if you think that please do something, help in some way to relieve his pain, I can be doing something, and the medication can be increased, but there is always chance of risk to life, not because of this medication, but because of his deteriorating general condition.
That is how you
honest communication and explaining the pros and cons of starting the medication.
Dr. Meenakshi, would you add anything at all?
Yeah, I mean, essentially, it's the same thing. Basically, you have to communicate very clearly. Our intent is to only relieve suffering, and if death occurs, it is a result
Well,
of the
inevitable.
progression of the disease and not the medication itself. And sometimes the medication, I mean, it's
May
just a
hasten the
doc.
process.
Yeah, it can hasten the process because sometimes it's the doctrine of double effect. But the intent is to, relieve the suffering. That is something that they need to understand. But some of these conversations are better held when the patient is not very critical, and
I
there is
actually do
time.
not mention the doctrine of double effect, madam, because they feel that if it is hastening, then I don't want.
No, I don't mention it
Mhm.
also. I mean, I'm just
Mhm.
saying for the learners here so that they understand that, that risk is there. It's not that it is bereft of that risk when you use certain drugs. And that's mostly for the morphine and benzos. But, we don't have the same risk with, and not everybody requires opioids. That's the whole point. So we have had patients who had malignant bowel obstruction. We maintain them at home with haloperidol.
No, I
And,
was speaking about patients who are already in hospital, and we are called upon to provide this care, meaning we run the acute pain service. So they feel that,
yes.
they would, yeah, but the intent and the thought processes are very different. So which drug would you recommend in that case?
No, I mean, morphine is the go-to drug, no doubt about it. But when you're saying the patient is in the hospital and you're providing only for pain management, in that
Well, it's
case,
not for pain management. I think it is the patients are usually unconscious. The relatives
okay,
are sitting by the side,
all
and
right.
they are distressed because of the patient's tachypneic, the patient's
Oh, yeah,
gasping.
they're gasping that way. Yes, but sometimes, despite a lot of morphine, the gasping is something
That is
which you
true.
cannot
That is
take
true.
away.
Yeah.
You cannot take away. And if the respiratory rate is already low, I wouldn't start opioid. Or if I see clearly that the patient is not having pain, we can administer non-verbal pain scales and see that if the patient is not in pain, then I would not go with morphine. Patient's already sedated, as by RAS scale -4. I wouldn't use morphine. I would use, if at all there is something to be used, reduce the secretions or,
Yeah.
just that. Otherwise, I wouldn't use. There are patients where we haven't used anything and we just observe. Sometimes the biggest pain is the oxygen mask which is on the patient's face. Actually, you reduce that 15 liters of oxygen, patient will be gone in a few minutes. But no, we have that oxygen on, and we want the saturation to read 92 all the time or 99 all the time. That is the biggest hindrance. So
I
a
think
lot of
Yeah, I remove the monitors totally when the
yes,
patient is
yes,
expected to die. Better to
absolutely. All
remove.
the time sitting and monitoring the saturation, it's just unnerving.
so basically it's the counseling that matters.
Yes, a lot of communication, basically
Talking,
communication, and that.
and a lot of talking.
Yes, yes. They need
Okay.
to actually come to you and say that, they're suffering and, can you do something about that? And very, I don't know, this was a very crucial point that Dr. Praneeth had mentioned in his slides. Just for the benefit of audience, I would like to reiterate not all patients are suitable for death at home. That may be the ideal situation or that may be the preference, but there are patients who will be better off in the hospital or a hospice or in a nursing home near their home. Sometimes you cannot provide very good end of life care at home. So it is a very individualized approach. So it's not a one size fits all situation at all. So every case is going to be different.
Thank you so much.
I think it's 7:35. I mean, are we supposed to close, or there was a very interesting case on the same lines yesterday? If there is time, I could share it. But it's 7:35. Is that okay?
Yeah, we can take 5 minutes.
Okay. Okay. So we had a very young child yesterday from Kadapa district. She was a non-metastatic osteosarcoma when she came 2 years ago. But unfortunately, the child progressed in the last few months and, in fact, hadn't even come to the palliative care OP. She was lost to follow up. But suddenly, she made an appearance last night with acute shortness of breath. So much so the entire left hemithorax has been replaced by a metastatic lesion. And she was absolutely in type 1 respiratory failure. So she was unfortunately, due to lack of advanced directives or an advanced care plan, placed in the ICU with high frequency nasal oxygen. And his parents by early morning had decided that they need to go to Kadapa, come what may. This is a patient without oxygen. Her SATs was 70, which means if I was removing the oxygen, she's going to go off in a whiff. And believe it or not, when we were trying to give her some morphine to just alleviate her distress a little bit and, allow her to sleep, just get some shut-eye, her mother was actually, waking up the child violently. Open your eyes, don't go to sleep. She was very worried that she understood that she's going to lose her child. A very, very heart-rending scene. And despite our counseling, this patient wanted, the parents were very insistent on taking this patient home to Kadapa, 250 kilometers away from Chennai, in an ambulance with oxygen. They just wouldn't listen to any reason. So finally, I was very unhappy about this decision because I had used a translator and I tried to convince them that this is not the time to move. Respiratory rate is 56, 160 is the heart rate. The child looks like she's going to collapse anytime. But no, they wouldn't listen. And finally, we said, okay, this is what you want, so be it. So we gave her some morphine. She just kind of slept and they transferred her into the ambulance. They took all the anticipatory medications, like Dr. Praneeth mentioned, all tablets, of course, because with going to Kadapa and with the caregivers who are not qualified, rather who are not in a position to understand subcutaneous medications, there was really no time or point in this explanation. So we gave some tablets and with clear instructions of use. And finally, within 20 kilometers distance of Chennai, from our hospital, the child passed on in the ambulance. So in this particular case, actually, this was not ideal. This is not how it should have been. Ideally, we should have given her palliative sedation with the consent of the parents because the child was 6. She couldn't have participated in this discussion. She was too sick already. But ideally, she should have received good sedation. She would have slept through this. Her mom could have had her in her lap and it could have been so much more smoother. But, sometimes, you just have to accept what the parents want. Yes.
It's very heart-rending.
Absolutely.
So I think there are no further questions, right?
Yes, not that I can see. No, nothing else. Nothing else.
So I take the opportunity to thank both of you.
Thank you. Thank you.
It was a pleasure.
Thank you for the opportunity.
Yes.
Thank you, Anjali madam,
Audience for
Meenakshi
staying
madam,
back
all the participants.
and listening to the entire session. Thank you so much. If there are any further questions, please feel free to post it in the group. Good night.
Good night.
Good night.
Thank you.
Thank
Thank
you.
you.
Thank
And
you,
Happy New
everyone.
Year to everyone.
Happy
the
New
time.
Year in advance.
Ankita, can you? Ankita? Right. So thank you everyone and good night.
Thank you, ma'am, for presenting such insightful presentation. I hope you had a seamless experience. So with all your permission, ma'am, we are signing off for the session now. Good night and a happy new year in advance to all of you, ma'am.